Chapter 9. This is going to be one of our funner sections on EMT, and we'll start talking about airway management. We're going to talk about airway physiology, the physical structures of the airway, and the pathophysiology, how they work, and how we can open the airway, and then different things we can use to keep the airway open. How to suction to clear out any type of vomit or debris that's in the airway, and then the definitive care and what we actually want to happen with airway maintenance. So, the upper airway begins at the mouth and nose. Air is warm and humidified in the nasal turbinates. The pharynx is the back of the throat, or the throat. The oropharynx, nasopharynx, and laryngopharynx. There's the upper, middle, and lower. Look on page 193 and you can see where the nasopharynx starts at the back of the nose, goes down to about the oropharynx, which then starts the middle portion of it, and then back on down farther to where the trachea and epiglottis actually start, and then it ends down by the vocal cords. Larynx, vocal cords. So here's a more accurate picture. This is the one that's in your book, page 193. So study that and be very familiar with it. The lower airway. It begins below the larynx. It's composed of the trachea, the bronchial passages, and the alveoli. And here's a picture of the lower airway and the bronchial tree. You see where the trachea divides into the right and left main bronchus, and then they divide further down. You see that the right is a little bit straighter than the left as it branches off. The alveoli are tiny sacs in grape-like bunches at the end of the airway, and they hold the oxygen. Okay, they're surrounded by pulmonary capillaries, and those capillaries then the oxygen goes across their permeable membrane, and the carbon dioxide, they diffuse across so that the carbon dioxide can be eliminated, the oxygen can be picked up. Oxygen and carbon dioxide diffuse through pulmonary capillaries and membranes. And here's another picture of the lower airways, the bronchioles, and where they connect into the alveoli and the air sacs, and that's how air needs to get in. Now those structures can become blocked too. The bronchioles can become swollen shut, or they can be blocked with mucus, such as in pneumonia. Or if you've got a bronchitis, you get mucus and the swelling. And just think, if those lower airways swell, those bronchioles swell and close, you're not going to be able to get that air to go into those alveoli sacs. You might hear wheezing as those structures become more and more constricted, such as in an asthma case. Airway pathophysiology. There's a variety of obstructions that interfere with airflow. You can have a choking type situation where some foreign object like food or small toys or pennies or anything can become trapped in that airway and obstruct it, and then they're choking. You need to relieve that obstruction, because if they don't get oxygen in and out, then they're going to die. Liquids, blood, and vomit can also obstruct the airway. Suctioning would help that. An obstruction may also result from poor muscle tone caused by altered mental status. The number one structure that blocks the airway is the tongue. So, any obstructions can be acute or chronic. Be familiar with those terms. Acute is something that happens suddenly. Chronic is something that happens over a longer time. So you need to evaluate the airway and monitor whether it's open or not. Patency is being open. You need to monitor that patency over time, because any indication that the airway might be swelling or closing, you need to be prepared for that. So if they've got hoarse talking, then they've probably got some damage going on that might cause some swelling or result in swelling. Stridor is also the swelling of the airway. Stridor is a high-pitched sound in the upper airway. It kind of sounds like this. Hey! Hey! So airway obstructions, the acute ones, the ones that happen suddenly, would be things like choking on foreign objects, vomit, blood. If it's occurring over a long time, it might be something from swelling or edema. Remember, swelling in the structures? That can result from burns, trauma, or even infection. And you may see a decreasing mental status or an altered level of consciousness in folks that over a period of time are having problems. Other airway obstructions could be the bronchioles constricting. The bronchioles, those lower airways, are maybe swelling or constricting. And it can happen from a disorder of the lower airway, such as asthma or emphysema. But the smooth muscle constricts the internal diameter of the airway, and now the oxygen can't get into the alveoli, and what air gets in there might actually end up trapped in there and can't come back out. Airway is so important that we do it at the very beginning of our patient assessment. It's all about oxygen, getting it in, circulating it around. And get the waste product out. So when we talk about ABCs, you do those in the primary assessment. The purpose of the primary assessment is to identify and treat life-threatening injuries. So 2 questions you need to ask yourself when you're evaluating the airway. Is it open? And is it going to stay open? In most patients, you can determine whether or not the airway is open simply by saying hello to them. And if they respond, hello, and it all seems normal and their breathing seems normal, the airway is obviously open. If they can talk, it's open. You need to look also at positioning of the patient. There's something called the sniffing position. This is a little bit more prominent in an infant, but when they're sitting upright and they're kind of putting their neck and nose forward, they call that the sniffing position. Imagine yourself going to smell some flowers that are in a vase. You kind of put your head forward and sniff just a little bit with just a slight tilt of your head. Well, when you see that, then there might be some swelling obstructing the airflow through the upper airway, and they're trying to optimize position to get the best. So, some indications that might mean that the patient is having breathing problems. If they can't speak in a full sentence, if they're just speaking in one word at a time and having to breathe, if they have an unusual raspy quality to their voice or they're hoarse, if you hear that stridor, that upper airway wheezing, if you hear snoring, the tongue falling on the back of the throat, could mean there's an obstruction. Tongue is the number one thing that blocks the throat, the airway. Gurgling would be an indication that maybe there's something in there that's going to block it, that needs to be suctioned out. Airway assessment is not just a moment in time. You got to constantly go back and reevaluate and reevaluate. If the patient does not have an adequate airway, you don't see any signs of breathing or air movement, you might not, um, you might suspect or have evidence of choking going on in the airway. You can't feel or hear any air coming in or out. They're unable or they're having a difficult time speaking. They have an unusual hoarse or raspy voice. There might be absent, minimal, or uneven chest movement. All may mean that they have an airway problem. The abdominal breathing. If they're using their abdomen a lot to breathe, excessive movement there. If they have diminished or absent breath sounds. So if you've got your stethoscope, that's something you need to take and listen to when you're doing your primary assessment. So you might see hear some abnormal noises such as wheezing, crowing, stridor, snoring, gurgling, or rasping during breathing. These are all unusual sounds. In children and infants, you might even see their nostrils flaring, trying to get as much air in as possible. They use their noses a lot to breathe. They're nasal breathers. In children, retractions above the clavicles. They're using those muscles in their chest to try to breathe in and out. If they have an obstructed airway, you're going to do the Heimlich maneuver.
As part of emergency training, medical assistants should be ready to respond to an adult with an obstructed airway. A bolus of food is the most common object adults choke on. When the food is lodged in the upper airway, the person may put his or her hands around the throat, the universal sign of choking. If the person can wheeze, make a high-pitched sound, cough, or speak, do not take any action. Instead, call 911 and encourage the person to continue to cough forcefully to try to dislodge the object. If the person is unable to speak or cough, he or she is in immediate danger and action must be taken. Materials needed to demonstrate proficiency in this procedure are an approved mannequin, gloves, and a ventilation mask with a one-way valve for unconscious victims. Once it has been established that the victim is choking, direct someone to call 911 and say clearly and loudly, "Are you choking?" or "Can you speak?" If the answer is no, as indicated by a head shake, tell the victim you are going to begin emergency treatment. For demonstration purposes, a coworker will simulate a victim in need. Stand behind the victim with your feet slightly apart, placing one foot between the victim's feet and one to the outside. This stance will give you greater stability. If the victim should pass out, you can safely guide him or her to the ground by sliding him or her down your thigh. Place the index finger of one hand at the person's navel or belt buckle. If the victim is a pregnant woman, place your finger above the enlarged uterus. If the person is very pregnant and the uterus is pushing the stomach and other internal organs under the rib cage, you may have to perform compressions. Make a fist with your other hand and place it, thumb side to the victim, above your other hand. Place your marking hand over your curled fist and begin to give quick inward and upward thrusts. There is no set number of thrusts to give to an adult who remains conscious. Continue to give thrusts until the object is removed or the victim becomes unconscious. If the victim becomes unconscious, gently lower him or her to the ground and put on gloves if available. A CPR mannequin will be used for the rest of the demonstration. Before administering rescue breaths, open the airway with the head tilt chin lift and look for a foreign body in the victim's mouth and remove if visible. Blind finger sweeps are no longer recommended and should not be performed. Immediately begin CPR with 30 chest compressions and 2 rescue breaths. Use a ventilator mask if available. Continue with cycles of 30 compressions and 2 rescue breaths until the foreign body is expelled or advanced medical personnel arrive to relieve you. If the object has been successfully removed and the patient did not lose consciousness, the patient may feel he or she no longer needs medical treatment. As a rescuer, you must insist that the victim seek medical attention anyway. The lodged object may have caused swelling in the lining of the esophagus, constricting the throat and impairing breathing.
Opening the airway. These are tasks you can do to make sure the airway is open. In the airway, when your primary assessment indicates that the airway is inadequate and there might be the threat of it being blocked, then you need to take prompt action and maintain the airway. That's the very first thing. You don't move on to the next step until you take care of this. If the airway is not open, you can maybe reposition it to make sure it opens. There might be some possibility that they have head, neck, or spinal injury, and these are based on the mechanism of injury. Maybe they, fell from a roof or were hit by a car. So if there's any injury at or above the level of the shoulders, if family or bystanders give you information that leads you to suspect that they might be head, neck, or spinal injury, then you would open the airway, not with a head tilt chin lift, but with a jaw thrust. The head tilt chin lift maneuver and jaw thrust maneuver move airway structures into position and allow the air to move in and out on its own. So head tilt, chin lift. Put one hand on the forehead, the other hand on the bony part of the chin, and gently tilt the head backward. You're tilting the head backward to bring the airway more into alignment, but you're pulling that chin forward because the tongue is attached to it and it's bringing the tongue off the back of the throat. Place one hand on the patient's forehead and fingertips of the other hand at the center of the patient's lower jaw. Tilt the head, lift the chin. Don't allow the mouth to close. The jaw thrust maneuver. If you can reach your fingers, and you've got to be at the head of the patient, just like in the picture, underneath where the jaw, the lower jaw, or the mandible connects, back there at the back by the ears, those fingers push the jaw forward. Your thumbs are on the cheeks. So keep the patient's head, neck, and spine aligned. Move the patient as a unit into the supine position. Kneel at the top of the patient's head. Place one hand on each side of the patient's lower jaw at the angles of the jaw below the ears. Stabilize the patient's head with your forearms. Use your index fingers. Push angles of the patient's lower jaw forward. You may need to retract the patient's lower lip with your thumb to keep the mouth open. Do not tilt or rotate the patient's head. After the airway has been opened, position may be maintained to keep the airway open. The airway might need to be cleared of secretions or other obstructions also. This is where airway adjuncts come into place, because it's hard to sit there and hold a patient's head for the entire transport to a hospital. And so we use airway adjuncts to help keep the tongue off the back of the throat and the airway open. Airway positioning and maneuvers are short-term solutions. An airway adjunct provides a longer-term air channel passage. So, two most common airway adjuncts for EMTs to use: the oropharyngeal airway, or OPA, or the nasal pharyngeal airway, NPA. Use an OPA only on patients that don't have a gag reflex, because this goes back in behind the tongue and holds the tongue forward. So you have to put the airway manually or open the patient's airway manually before using the adjunct device. So you need to open it with the jaw thrust or the head tilt chin lift. When you put the airway in, take care not to push the patient's tongue back into the throat. Have suction ready prior to inserting any airway, because this might make them vomit. And don't continue putting that airway in if the patient gags. You need to take it out. Maintain the head position after airway adjunct inserting, and then monitor the airway. Always be ready to suction if fluid or blood obstructs the airway. And if the patient regains consciousness or develops a gag reflex, remove the airway immediately. Always wear your gloves for this and any other infection control. Depending on how much vomit there is, you might need a mask and goggles. An oropharyngeal airway just moves the tongue forward off the back of the throat. They're different sizes. There's infant to a large adult. And these, sometimes they're color coded like this, but either way they need to be sized before you put them in somebody's mouth. And this is how you size it. You ensure the oropharyngeal is the correct size by checking to make sure it either extends from the center of mouth to the angle of the jaw, or from the corner of the patient's mouth to the tip of the earlobe. And you see, if you flip that over, it'd be about the right size to keep the tongue off the back of the throat. So, inserting an OPA. Place the patient on his back and use appropriate method to open the airway. Open the mouth with a crossed finger technique. Position the airway with the tip pointing towards the roof of the mouth. And then rotate it 180 degrees when you put it in, because you're putting it in upside down. Here's the crossed finger technique to open their mouth. So, insert device along the roof of the mouth. Gently rotate the airway 180 degrees so the tip is pointing down into the patient's pharynx. Position the patient. Check that the flange of the airway is against the patient's lips. Monitor the patient closely. So, insert the airway from the tip pointing to the roof of the mouth. See how it's upside down? And as you go in, rotate it around to keep the tongue off the back of the throat. You can also use a tongue depressor or rigid suction tip to insert the oral airway directly. On infants, you should use a tongue depressor because the top of the roof of their mouth is very soft up there, and so you don't want to damage it by inserting that oral airway upside down and rotating. A nasal airway, nasal pharyngeal, is soft, flexible tube inserted through the nostril and into the lower pharynx, hypopharynx. It moves the tongue and soft tissue forward to provide a channel for air. Same thing that the oral airway does. This one is unique though, because if the patient has a gag reflex, you can still insert and keep the nasal airway in. It's contraindicated if you see cerebral spinal fluid coming from the nose or ears, because otherwise that nasal airway can actually go back into an opening and into the brain. Nasal pharyngeal airway comes in various sizes. You have to measure it once again. Typical adult sizes are 34, 32, 30, and 28 French. When you insert the nasal airway, measure it for correct size and then lubricate the outside of the tube with a water-based lubricant before insertion. Make sure it's water-based and not like Vicks, which is petroleum-based. Measuring it is from the nostril to the tip of the earlobe or to the angle of the jaw. Apply a water-based lubricant before insertion. KY jelly is water-based. Push the tip of the nose upward. Keep the head in the neutral position. Insert it into the nostril. Advance until the flange rests firmly against the nostril. So, bevel is towards the end, center, the septum. So gently push the tip of the nose upward and insert the airway with the beveled side toward the base of the nostril or towards the septum. And insert the airway, advancing it until the flange rests against the nostril. You see it, that the airway kind of curves the nasal airway. So, suctioning. You need to suction whenever you hear gurgling or there's obvious liquids, blood, vomit, secretions, and they need to be removed from the airway to prevent it going down into the lungs and causing a blockage there. So use a vacuum device to remove the liquids from the airway. We have different suction systems. Some of them are mounted in the ambulance, usually near the head of the stretcher, and they furnish an air intake of at least 30 liters per minute. And they'll generate a vacuum of no less than 300 when the tube you're collecting it in is clamped. Portable suction units have the same requirements as mounted ones. It's just that you can move around and actually take them with you to your patient's side. They're oxygen or air powered or powered by batteries or electricity. Or they're also manual portable suctions that are kind of like turkey basters or syringes. Tubing, tips, and catheters used in suctioning. We have various lengths of tubing. They're pretty universal. They'll connect to each other, different brands. And there's two different types of suction tips and suction catheters, which we'll talk about in a little bit, and we're going to demonstrate and play with in class. And then you have the collection container. You should also keep a container of clean or sterile water close by, because if you get some really chunky or thick secretions that you're suctioning, the tubing and the catheter may become clogged, and then you can put it in clear water and actually clear it out. Here's an example of a suction unit installed on the ambulance patient's compartment. The types of tubing, tips, and catheters. There's a rigid pharyngeal suction tip. It's also called a yonker. It's much larger than the flexible catheters, and it's pretty rigid actually. But it can suction larger particles and thicker secretions. This is an example of a rigid tip. And when you suction, you put it into the patient's mouth. There's usually a hole that's somewhere along the side of the suction tip. You need to cover that hole with your finger in order for suction to happen. So the rigid pharyngeal suction tip. Suction only as far as you can see. Don't lose sight of the distal head, the one farther away. Careful insertion helps prevent gag reflex or vagal stimulation. The vagus nerve is a nerve that travels down from our neck down to our heart, and it actually will slow our heart rate down if it's stimulated. So you can actually stimulate the vagus nerve towards the back of the throat. Flexible suction catheters are designed to be used when a rigid tip can't be used. You use flexible suction catheters on infants also. You can pass that through a tube, such as a nasopharyngeal or even an endotracheal tube, and suction down into the mouth. And it can be used for suctioning the nasopharynx. It's a little gentler than the rigid tip. They come in various sizes, and they're usually sized by French, 26 French, 14 French, 7 French. The larger the number, the larger the catheter size. They're not typically large enough to suction a lot of thick vomits or thick secretions, and sometimes there's problems with them kinking. If there's a lot of thick secretions and a lot of vomiting, you might remove the tip or catheter and use a large bore rigid suction tubing. You measure catheters, flexible catheters, in a similar way as you measure the oral airways. The length of the catheter that should be inserted into the patient mouth equals the distance between the corner of the patient's mouth and the earlobe. You don't want to go any farther back than what you can realistically see. Here's the measuring of a flexible suction catheter. You see? So hang on to that end where you see that's as far as it goes, and then suction. Use appropriate infection control practice. Use protective eyewear, goggles, masks, and disposable gloves. Position yourself at the head of the patient and turn their head or entire body to the side, and then you'll be suctioning, and then if anything comes out extra, it'll go to the side and not down their throat. Suction no longer than 10 seconds at a time. While you're suctioning, you're sucking out oxygen that may be in their body, and prolonged suctioning can cause hypoxia or low oxygen levels, and also bradycardia, a slow heart rate. If the patient vomits for longer than 10 seconds, you need to continue to suction. It doesn't do any good to put all that down into the lungs where it's going to cause more damage. Place the tip or catheter where you want to begin suctioning and suction on the way out.
The oropharyngeal airway flange rests against the lips. The rest of the device holds the tongue as it curves back to the pharynx. Carry a complete set to ensure the proper size, which extends from the mouth's corner to the earlobe's tip. Place the patient on their back and perform a crossed finger technique. Position the airway's tip so that it points towards the roof of the mouth. Slide the airway along the roof of the mouth past the soft tissue, uvula, or until resistance is met against the soft palate. Gently rotate the airway 180 degrees so that the tip points down to the pharynx, which prevents pushing the tongue back. On an infant or child, insert with tip pointing down toward the pharynx, using a tongue depressor to press down and forward. Ensure that the flange is against the lips. Place the mask over the in-place airway adjunct. If there is a gag reflex, remove the adjunct at once, following the anatomical curvature. Some EMS systems allow an oropharyngeal airway to be inserted with the tip pointing to the side of the mouth. The device is then rotated 90 degrees so that its tip is pointing down to the pharynx. The nasopharyngeal airway is used when there is a reduced level of responsiveness but still a gag reflex, or when the teeth are clenched and there are oral injuries. Measure the airway from the nostril to the earlobe or the angle of the jaw. Apply a water-based lubricant. Gently push the tip of the nose upward. Keep the head in a neutral position. The bevel or angled portion at the tip should point toward the base of the nostril or toward the septum. Insert airway into the nostril. Advance until the flange rests firmly against the nostril. If you experience blockage, try the other nostril. Materials that remain in the airway may be forced into the trachea or lungs, which can cause complications including pneumonia and airway obstruction. Suction when gurgling sounds are heard before, during, or after artificial ventilation. Put your finger over the proximal port. Suctioning begins from the distal end. Place the catheter where you want to begin suctioning and suction on the way out. Alternate suctioning for no more than 15 seconds with ventilating for 2 minutes. With suctioning, always use appropriate infection control practices. If gagging begins, withdraw the tip to a position where gagging stops.
So, keeping the airway open and definitive care. So, keep the airway open might exceed your capabilities as a basic EMT. There are some advanced procedures that will help to keep the airway open. It might be some medications or surgical procedures that might be necessary to resolve airway obstruction. So you need to rapidly evaluate and treat airway problems. You can't move on until you fix what's blocked, because it's all about getting the oxygen in and the air and the carbon dioxide out. So quickly recognize when more definitive care is necessary. You might need advanced life support intercept to do some advanced airways, or you may just have to go to the closest hospital so that they can fix. If you are not able to manage an airway at the basic level, what advanced resources might be available to you? In our system, the Galesburg system, Galesburg Cottage Hospital, we are allowed to use King Airways, and they are a blind insertion advanced airway that allows you to keep the airway open and maintain control so that it doesn't become blocked. Some facial injuries. Sometimes severe swelling or bleeding may actually block or partially block the airway. So you might have to suction frequently or put in a more definitive airway to keep that airway from becoming blocked. Obstructions. Many suction units are not adequate for removing solid objects. You might have to do the abdominal thrust, chest thrust, or finger sweeps to actually get an object out. Dental appliances are best left in place during airway procedures whenever possible. If they're dislodged, though, it's just easier for you to take them out during an emergency. Don't lose track of them, though. Be prepared to remove any dentures if the airway is endangered. There's a variety of anatomical difference to consider when managing the airway. Some people have smaller mouths and nose and more difficult to keep their airway open. Larger tongues, especially kids. They're going to have small mouth and nose, larger tongues, and then that narrow, flexible trachea that can become easily blocked. And here's your pediatric sizing compared to the adult. Do you see they have a smaller mouth and nose? More space is taken up by the tongue. Their trachea is narrower. The cricoid cartilage is the least rigid and less developed, so their windpipe can collapse more easily. Airway structures are more easily obstructed there. So, what do we do for kids? Well, open the airway gently. Don't hyperextend the neck, because too far back or too far forward could actually kink that small little trachea. Consider adjuncts when other measures fails. Use rigid tip with adjunct, but do not touch the back of the airway. And here's our review. The airway is the passageway by which air enters the body during respiration or breathing. A patient cannot survive without an open airway. That's why it's one of the first things we do. It's in the primary assessment. Find and treat life-threatening conditions. Not getting oxygen in to the body is a problem. A patient can't survive without an open airway. You can use airway adjuncts. The oropharyngeal and the nasopharyngeal airways can help keep the airway open. It might be necessary to suction the airway or to use manual techniques to remove fluids and solids from the airway before, during, and after artificial ventilation. It's kind of a constant process over and over again. Always use proper personal protective equipment when managing an airway. Lots of vomit and stuff, you might want to cover your eyes and nose and mouth so that there isn't an opening for any diseases. Airway management should start simple and become more complicated only if necessary. Name the main structures of the airway. What are they? Well, you got your mouth and your nose, your nasopharynx, oropharynx, laryngopharynx, trachea, bronchi, bronchioles, alveoli, and don't forget our diaphragm is also a part of our respiratory system. Explain why care of the airway is the first priority of emergency care. Because if you can't get oxygen in, then you're not going to be able to circulate it around and get it to where it needs to be. What are signs of inadequate airway? Noisy breathing, noisy respirations. They can't speak in a full sentence. You're going to see changes in mental status. Explain when the head tilt chin lift maneuver should be used and when the jaw thrust maneuver should be used to open the airway. Well, the head tilt chin lift is for anyone you do not suspect has a spinal injury. Jaw thrust is used if they have a spinal injury that you suspect so that you don't aggravate it. Explain how airway adjuncts and suctioning help in airway management. Well, the oral and nasal airway keep the tongue off of the back of the throat, and suctioning helps keep the vomit and secretions out of it. On arrival at the emergency scene, you find an adult female patient with gurgling sounds in the throat and inadequate breathing slowing to almost nothing. How do you proceed to protect the airway? First things first, it's an airway problem. Gurgling. Something is in there obstructing it. It needs suctioned. Gurgles, gurgle, gurgle, needs suction, suction, suction. When evaluating a small child, you hear stridor. What does this sound tell you? What are your immediate concerns regarding this sound? Stridor is an upper airway obstruction, swelling in the upper throat. Kind of it's actually around the laryngopharynx. So what does it sound like? What are your immediate concerns? The airway is swelling shut. You need to do something. You need to start giving oxygen and try to keep their saturations up and the air moving through it. Why is the airway being swollen shut? Is it because of burns? Is it because of an allergic reaction? There's fluid leaking out and causing swelling. When assessing an unconscious patient, you note snoring respirations. Should you be concerned with this, and if so, what steps can you take to correct this situation? Well, what's the cause of snoring respirations? Most likely, it's the tongue falling back on the throat. What do you do when your spouse is next to you in bed snoring? You reposition them, right? You elbow them till they reposition and their airway opens back up and they're not snoring anymore.